Hi, everyone, and welcome to another episode of the Sarcoma Sisters. We're here today with Safia Ahmed, Dr. Safia Ahmed, who is a radiation oncologist at the Mayo Clinic in Rochester. So she actually works with Wendy. And we're so happy to have you here today. She is an expert who does radiation oncology, but specifically works with sarcoma patients. And I think with radiation oncology, it's one of the great mysteries of 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 for parents and for patients, because like we talked about with pathology, where people don't actually see the pathologist, but they do meet their radiation oncologist. But still, it's one of those areas where there's a lot of questions. And even when your radiation oncologist goes over everything, we know when anybody gets information for the first time, there's a lot of overwhelm. So I'm sure there's a lot of questions when they go home too. And so we're so happy to have a radiation oncologist on with us who's an expert in sarcoma, so we can talk more about it. So welcome and thank you for being here.
Thank you for having me. I'm excited to be here.
Yay! So I think what I was going to kick off with just first asking you, I have so many questions, but could you just let us know, and you can even tell us how you would tell a patient, what is it that a radiation oncologist does in general? And then we can get more specific.
Sure. So yes, I agree with you. Radiation is such a black box, and it's one of those fields in medicine that no one has exposure to unless, unfortunately, you've been diagnosed with cancer or have a family member or close friend who shares with you that they have cancer and needed radiation. But as a radiation oncologist, I am a cancer doctor that specializes in using radiation treatments of all kinds to treat patients with cancer. It's considered to be a local treatment. So what that means is that radiation would only target specific areas of the body that have cancer that we choose to target with radiation. When I am thinking about radiation treatment for a patient, I first have to think about whether the cancer is sensitive to radiation and would respond. I have to think about the body part that the cancer is located in and whether it's safe to give radiation there or not. I also have to work closely with my colleagues in pediatric and medical oncology and surgery to see if radiation would supplement their treatments for the overall goal of cancer cure or symptom relief. And then I also have to decide how best to deliver the radiation treatment. What that means is what type of radiation would I use, how much total radiation dose do I give, and over how many treatments I give the radiation. And then I help design the radiation plan with the team and oversee the delivery of the radiation and follow up in terms of side effects from treatment.
It's a lot of work.
Yes.
Thanks. That's a
I
very
love
good
it.
overview.
Can you explain in like really simple 3 or 4 sentences what is radiation?
Okay.
Like, what is it?
What is it? Yes. So, the most common form of, so this might be more than 3 or 4 sentences, so I apologize.
Oh,
okay.
grading.
But I'll keep
grading
it
you.
simple. So the most common form of radiation that's used across the United States is X-ray radiation. And it's exactly as it sounds. It's using X-rays to treat cancer. So I'm pretty sure all of us have had an X-ray at some point. We've either gone to the dentist and had X-rays of our teeth, or we've unfortunately injured ourselves and needed to get an X-ray of like our sprained ankle or something. So we've all had experiences with X-rays. We're using those same types of X-rays that you would get when you're getting something imaged, just bumping up the power of the X-rays so that when they enter your body and hit the cancer, instead of creating a picture for us, the high energy X-rays actually cause damage to the cancer cells. It specifically damages the DNA in the cancer cells. And when the cancer cells attempt to grow, because that's what cancer loves to do, it likes to grow. When it attempts to grow after it's been hit by radiation, it actually can't, because its DNA has been damaged and the cancer cell will then die because it has damaged DNA.
So is X-ray radiation the same as photon?
Yes, X-ray radiation means photon. It's our fancy word for it. I like to use the term X-ray with patients because most people understand what X-rays are.
And how do you boost up the power?
So we have a fancy machine that delivers the X-ray radiation. It's called a linear accelerator. And the parts inside the linear accelerator help basically amplify the power of the X-rays before they exit the machine and enter the body. And so that takes care of it for us.
Cool. Those are big machines if you've never seen one. Well, not all of them. Not all of them are big, but the first time I ever saw one, I was like, oh, fascinating.
Yes, they are
Um,
sophisticated.
yes, very fancy machines. So that's photon slash X-ray. I like X-ray. I've never used that word to describe radiation before in that way. So how many more do you have to go through? Let's go to the second one.
Yes. So basically, that's how radiation works. To kind of wrap up your question there, is we are using energy to basically kill cancer cells. X-rays is one kind of energy that we can use, and that's what we're most familiar with. There's other types of energy as well that can basically accomplish the same thing of killing cancer cells. So other radiation energies that can be used are electrons. We don't commonly use electrons for treatment of sarcomas or pediatric tumors. Electrons, just in the nature of how they travel through the body, actually are only good for treating superficial cancers, so more like cancers of the skin. And so you'll see that electrons are often used when we want to treat something that's on the skin, because it just travels, hits the skin, and then just stops shortly after that. It's not good for treating deeper tumors in the body. The other source of radiation that a lot of pediatric patients and many sarcoma patients benefit from too is proton radiation. And so the source there is protons. The protons are generated in a very, very, very big machine called a synchrotron. And they also work the same way as X-rays. They'll exit the gantry machine, and then they'll travel to the body, specifically targeting the cancer cells that we want them to target. And they work the same way. They damage the DNA of the cancer cells, and the cancer cells die.
What makes you choose X-ray radiation over proton radiation or vice versa when you're looking at a patient and making a therapeutic plan for them?
So we do have to think about it with every case. And factors that I look at, one is patient age, and then also location of the tumor, type of the tumor, and if they've had radiation before. So to explain the benefit of protons, so let me start with X-rays. So when X-rays enter the body, let's say you have a tumor that's in your brain. Let's say it's on the right side of the brain. It's a couple of centimeters in. X-rays will enter the brain. They'll target the tumor, and that's where most of the radiation dose goes, because we program it to do that. But X-rays keep traveling. They travel almost indefinitely. And so they have to exit the body at some point. So once they've done most of their damage at the tumor, they actually exit on the opposite side of the brain. So all of the brain tissue that's beyond the tumor, that doesn't need to be treated, sees radiation dose. It receives radiation dose. It's not as much as the tumor. It's a lot less. So it's not going to hopefully cause permanent damage, but that's where side effects come in, because you are exposing normal tissue to radiation. With protons, the same concept. You're going to have the protons enter the brain, target the tumor, but protons just stop very quickly after they treat the tumor. They don't have the property of wanting to travel indefinitely, and so they don't expose the tissue beyond the tumor to radiation. So you're protecting more normal tissue from radiation. And that could be a benefit in young kids. So pediatric patients are almost always treated with proton therapy because they are growing. Their organs have not developed fully, and you want to protect them as much as possible from radiation. So in the brain, you think about IQ development, and that's very important in kids. In the spine, you think about height, and that's also very important. So pediatric patients are almost always treated with that. There are certain types of, oh, sorry.
No, I said go ahead.
There are certain types of cancers that need a very high dose of radiation to be effective. So an example of that could be a rare sarcoma called a chordoma. And chordomas often happen near the skull base or the spine or the pelvis. And if they're in the spine, they tend to wrap around the spinal cord. The dose of radiation that we need to give for the chordoma to effectively treat it far exceeds what the spinal cord can tolerate. So if I try and do that with X-rays, it's not going to be safe. I can't treat the chordoma effectively, and I would damage the spinal cord. So Protons helps me do that. It gives me that high dose delivery capability while protecting the spinal cord because protons stop almost instantly. And so location in the body, as well as tumor type. And then finally, if patients have been exposed to radiation previously, if there are spots where we have to treat again, you want to protect normal tissue more the second time around, so you use Protons.
So I do have a question about that. So for like 10 years, I worked at the University of Arizona, and we didn't have a proton machine there. So many of our patients also didn't have the ability to travel. And actually, they just recently got a proton machine in Phoenix. So I think it's probably going to be that where a lot of patients might not have the opportunity still, even though there are more proton machines coming and being available in the US. So for those patients, are they still being treated adequately, would you say? Is it more of a protective measure, or because I know specifically for brain tumors, it makes sense to me, or spinal cord, where you wouldn't want that radiation to go through. But for these other tumors, is it that you always treat it or you feel like it's necessary?
So certainly case by case, but for pediatric patients, I strongly lean towards proton therapy. And as you pointed out, there are lots of proton facilities now opening, being constructed. So I think it'll be easier for patients, which is great. Because I think all pediatric patients, regardless of where the tumor is in the body, they're still growing. Their tissue still hasn't matured. So I think you're going to have a benefit for it regardless of where you treat. The main benefit is risk of secondary cancer in pediatric patients. So whenever we give radiation, we always talk to our patients about the risk of causing another cancer because like we talked about, radiation causes DNA damage. So it can damage DNA of normal tissues nearby, and that could lead to cancer production. So even if you have a small tumor that's in the arm, doesn't even involve the bone in a kid, you might say, well, nothing's growing there, nothing's maturing, they're not going to notice a difference long term. I would say, well, I'd still minimize the risk of normal tissue exposure, and that would minimize the risk of a secondary cancer developing down the road.
Yeah, I think that's an important point that you bring up, Lisa. Thinking about the people that listen to our podcast and just my interactions with my own patients and discussing patients. I am a firm believer that all parents want the best for their children and are seeking the very best care, and great care can be given at multiple centers across the country. But in certain geographic areas, accessing that care is more challenging. And we lean towards pediatrics and who we care for. And, I kind of go up into teenagers. And so I think it's important to know or to talk about with your treating team, like, is it appropriate for that proton referral? Or if you're a 17-year-old young woman who has reached their height potential and the sarcoma is in their leg, and you live in rural Montana and photons is the only thing available, talking with your team about how that affects your life going to a proton center versus receiving photons close to home. And it's so specific and so individualized, but it's the conversation that's important to have because there's those nuances to care. And I think especially now that I'm kind of back in more of a rural area, like back to my homeland, I think that's something that people struggle with, traveling distances and making sure that they're getting to the tertiary centers. And we're fortunate to have a proton center here, which is nice.
We recognize it's a challenge to come from a distance and to pursue treatment in another city, state. away from home for several weeks. So many proton centers are equipped with being able to provide resources for families who are traveling. So that's the only other thing I'd ask is don't be shy about asking for what resources there are. And oftentimes even having your oncologist or yourself reaching out to a proton center to see if this is something that can be accommodated with your potentially time restrictions, financial restrictions, and so forth. We are passionate about giving the best care for our patients. So we make it work as best we can.
Yeah, no,
Yeah.
that's a good
And
point.
yeah. And that really comes through, that you care, and that's why you're recommending this, and I think what both you and Wendy said were really great, because I had that conversation a lot with a lot of my families who were savvy and had the ability to, to go on the internet and search other things. Would ask about protons and then would decide whether or not. But then some of my other patients who were also savvy, but then didn't have the means to travel. When we're talking about Tucson to Phoenix, it's 2.5 hours, and that's not realistic to travel back and forth every day, especially when you have other kids at home. And so that point about the resources, I think, is so important too. So thanks for bringing that up, because I think that's something that sometimes we don't recognize or we don't think to ask about. Our social workers always think to ask about, but that a lot of times they can offer that, and if it is the best treatment, and I think that's so important to point out for growing children, versus like what Wendy was saying, like if you have somebody who may have already hit their growth peak, so it's not really going to have a big effect,
But it still doesn't, I mean, even a 17-year-old has a lot of life left to live. And so
Right.
that
Oh,
secondary
yeah, for the
cancer risk
secondary
is,
cancer.
yeah,
Right.
Yes,
yeah. So
definitely.
those are
Wha-
important things to
yeah.
bring up, for sure. I wanted to go back. You said when you were talking about the resources, you said something about several weeks. For sarcomas in particular, even though everything's kind of generalized, what is the typical length of therapy for radiation for a curative radiation therapy plan?
Right. So it ranges, but in general, it would be anywhere from about 4 to 7 weeks. So we can give radiation before surgery to help surgery be more successful. And in that setting, it's usually about 5 weeks. Sometimes we give it after surgery because, you attempted surgery, there was concern perhaps that cancer cells were left behind, positive margin, or the type of sarcoma that you have, even if it's a negative margin, has a high risk of coming back. So we want to do something additional. And that could range anywhere from about 4 to 6 weeks. And then sometimes we use radiation alone. Surgery may not be a good option. The tumor is in an area where if they attempted surgery, they would cause more harm because maybe it wraps around the spinal cord too much and you can't take out the spinal cord, or you're just medically not fit to undergo surgery. Then in that case, radiation could range anywhere from 6 to 7 weeks.
And why does it take so long? Oh, was that what you were going to say, Wendy?
Yes.
Why
So
can't you
the
be
way I
faster?
explain it to patients is I have to give a certain dose of radiation, a total dose, for it to be effective. It's like if we got diagnosed with pneumonia and had to take antibiotics. They don't give you the whole bulk of antibiotics at once. It's too toxic for your body. It's not safe. So instead, your doctor might say, take 2 to 3 pills a day, for this many days, and then, so many pills for this days. But anyway, bottom line, the course could be like 2 weeks. And you're getting your total dose of antibiotics, and you should hopefully be cured. It's the same concept with radiation. I can't give it all at once. I need to give it a total number. So I'm just splitting it up over several days or several weeks in this instance. And then by the end of that time period, you would have received all the radiation that you need to be effective.
So for patients that are going for their radiation consult, what does that look like on a daily basis of how you're delivering it? Are you giving it 7 days a week, 5 days a week, every other day, only on Mondays?
Right.
What you doing?
So when a patient is referred to our department, they meet with the radiation oncologist and the team, and we decide if radiation is beneficial, what type of radiation, number of treatments, and so forth. And then actually the next step that needs to be done is a radiation planning appointment. It's often called a simulation. It's called a simulation because we're simulating how we're going to treat you. So you can think of it as our dress rehearsal. At that time, we bring you into a CT scan room, and we lie you down on the treatment table. That's how most patients are treated, in the lying down position. I would say 99.9% of patients are treated that way. And then it's important that you not move during radiation, because we like to be as precise as possible. So during the simulation, we create immobilization devices around the body part that we don't want to move. So even if you're doing your best not to move and you accidentally sneeze, you're not going to move, basically.
I was just going to ask, what if you have to sneeze? I was
Yes.
literally thinking that.
You can sneeze. You can totally sneeze.
That's
So
great.
like, for instance, if we're treating anything in the brain, we're going to have a mask. It's a mesh mask that we shape to your head. We have to make it custom to your anatomy, whatever immobilization device that we do. So we make the immobilization device, and then we do a CT scan through that area. And the CT scan gives me the information I need to help define where the tumor is, to help define the area around the tumor that's also at risk and needs to be treated, helps me define where the normal tissues are that need to be protected. And sometimes we'll also get an MRI too, because that gives us a different view of things. So once we're done with that, patients are free to go home. It takes a couple of days to come up with the radiation plan. At Mayo, that could be anywhere from, for X-rays, a turnaround time of about 2 to 3 days, and with protons, a turnaround time of about a week, where I'm defining everything I need to treat, and I have a team that's working with me to determine how the radiation enters and exits the body, how much dose I'm willing to accept for normal tissues, and so forth. So it's a back and forth process of coming up with the optimal radiation delivery. And then when it's time to start, patients come in. Treatment is once a day, every day, Monday through Friday. The radiation therapists are the ones who are actually delivering the treatment. And so they would come into our department, check in, and then wait for their turn for their appointment. The therapist would meet them, take them back to the machine, help them into their mobilization device, get everything set up. We're all about safety. We take images, X-rays before we get started, or what we call very quick CT scans of the area we're treating to confirm everything is matching up. There's no change in anatomy, you're holding still, and so forth. And then the radiation therapists deliver the radiation.
Do you do those checks every fraction that you give, those checks to make sure everything's lined up, or is that?
Yeah.
Oh, I didn't know
Checks
that.
are done every day when I finalize the radiation plan. I said, I like this plan. I have a separate team of physicists who do quality assurance checks as well. So lots of checks along the way before we even deliver the plan on the patient. But positioning checks are done every day. If there's a question on the treatment machine that the therapists don't know how to address or don't feel comfortable, I get paged, or the radiation oncologist gets paged to come and take a look and helps resolve it. The images that are taken, if there's no issues, are sent to the radiation oncologist to review, obviously in a different area because we have clinic and whatnot. And so that gives us a chance to review things too as another check.
Awesome.
Yeah.
Cool.
The treatment times themselves, the actual time a machine is on treating you is often less than 10 minutes. But treatment times can range anywhere from 15 minutes to an hour, because we take a lot of time positioning patients and getting them into the correct position.
Yeah, a lot of my patients get tats from you guys. So
Yes.
I was gonna say, could you mention the radiation tattoos and if they're permanent and what those are for?
Yes. So we take images to treat patients before they get started, but oftentimes we like to use external markers or tattoos to get us into a closer vicinity before we kind of take the images. So they're kind of like external lining up markers. They're called tattoos. They're actually permanent ink. And it depends on which area of the body that we're treating. So if we make you a mask and we're treating up in the head, you don't need a tattoo, because they'll put the external markers on the mask itself and line up to that and then take images. But if we don't have a mask, and let's say you're just lying on the table for your spine and have something around your legs to prevent hips from moving, we still have to have tattoos. So they are about the size of, I would say, a pen, kind of the tip of a pen. And you'll usually get 2 to 3 tattoos on your body. And they honestly look like a freckle, and most people don't notice them.
So you have all these cool immobilization devices, and I have a 3-year-old.
Hmm.
And if I put a mask over my 3-year-old's head, he would flip out. So how do you deal with that?
Right. So yes, I agree. That would not be comfortable. And it's hard, even if we didn't have a mask, to get a 3-year-old to stay still for 10 minutes to an hour. So with pediatric patients, we often treat them with daily anesthesia. We have most radiation facilities, especially pediatric radiation facilities, are equipped with an anesthesia suite and a team to help with daily treatments. They are treated usually first thing in the morning because they need to be fasting for treatment, and you don't want to have a 3-year-old wait till 4 p.m. fasting. So they're treated first thing in the morning. And when they're anesthetized, they don't move. And then we make the immobilization device.
Yeah, I think that's important for people to know that even the squiggly wigglies, you're able to do it safely, and the safest thing to do is to give them sedation so they don't move while you're trying to do these things.
Right, right.
I had another question. I forgot it, Lisa.
Oh, well, while you're thinking, I was actually going to ask about the plans. Those plans are amazing and mathematically and visually pleasing. They look so cool because they have all the colored
The
lines. I
rainbow.
was wondering, yes, do you share those with the patients or can they ask or how does that work? Because I know we can usually, like when I used to work at U of A, like I could access the plans to look at them, but not that I could interpret them, but I could explaining where the radiation goes. And
Right.
do you use those when you talk to the patients?
Yes. So unfortunately, they're not a part of the medical record. So it's not something the patient
That's
can
right. I do
access.
remember that too. Yeah, I forgot about
Yes.
that. Mhm.
So, and many times, if I have a difficult case, I am telling patients I might not know what the exact risk is to this normal tissue until I design the plan itself. So oftentimes I do have to follow up with patients on what I came up with after our
Mhm.
initial consultation. We have the ability to pull up the plan and show patients. It depends on each institution, and the computers for the radiation planning are a little bit different than your typical clinic computers. So it just depends on computer capabilities and where you are. But yes, patients have a right to ask to see their plan. I encourage them to do so. We review the plan with them. It may not be exactly the plan itself. We may
Mhm.
print off representative pictures, or we may descriptively talk about it too. If you've had radiation and need to consider radiation again or are going to another institution for that, your radiation oncologist at your new institution will request prior radiation records too. So they are something that can be transferred from facility to facility.
I remember my question. I got it. So you have this plan that is all rainbow colored and super
Mhm.
sophisticated, and you're checking every day. Do you ever adjust the plan? Like, say you're 3 weeks in, do you ever adjust it?
Mhm. So radiation for a couple of reasons. Radiation can cause swelling of the cancer because it's being damaged, it could die, and there's swelling that happens. So sometimes the treatment target now is bigger than what it was, and the radiation plan's not covering everything it needs to. So we may have to scan again and re-optimize the plan. Sometimes patients lose weight, sometimes they gain weight. There's nothing wrong with that. I mean, our patients are
No
getting,
judging.
chemotherapy that could affect their appetite. They're having other side effects. They might be on steroids that could affect their weight. So we're monitoring for that too. And if you don't fit in your mask because you've gained weight from steroids, then we have to make a new mask and kind of do things again. But yes, we can do that especially if we feel the treatment plan is not optimal due to anatomy changes.
Thank you. And if you had a tumor, hypothetically, if you had a tumor that was on your arm and you could see it, you could see the bump,
Mm-hmm.
is there like an average time that you start to see that tumor go down after you start radiation? Or is it super variable and you can't really give me an answer?
So with sarcomas in general, they don't tend, it's not gratifying from my point of view because they don't really respond during radiation. There are certain tumors that just melt away with radiation as soon as you start. So like lymphoma is a classic example
Mhm.
where you give the radiation, you give chemo and you can start to see a difference. Sarcomas, I would say most of them don't respond that way. Some of them can, but most of them don't. And so And it's disheartening for patients too, because they want to see things respond and shrink, and it's not. And sometimes, and more often than not, it's getting bigger because it's swollen. So what I tell patients is that don't be disheartened. The swelling is expected. And it's because obviously the cancer is responding to the radiation. It's getting bigger because of the swelling, and that's okay. And I don't expect things to shrink during radiation. I tell patients that radiation continues to work for up to 3 months after we're done, because that DNA damage happens with each treatment. And a cancer cell may not try to grow until maybe a month after treatment, or 2 months, or 3 months. And it'll only die when it attempts to grow. So radiation continues to have its effects for several weeks to a couple of months afterwards. And then we usually scan about 3 months after we're done. And even then, you're not going to see a dramatic shrinkage, because the swelling is now starting to come down. And so from that scan, we then look at subsequent scans to see what the response is.
It was going to be the next thing that I said that I asked, or I don't know what I'm saying. Maybe don't include that, Lisa. I'm just kidding. Is that, our patients with sarcomas, we talked with a family about all of these scans that we get, whether they're for treatment planning or disease surveillance or, disease response assessments. And oftentimes my patients will ask me at like week 5 of radiation, if it's a 6-week plan, like, okay, have you scheduled the scan to check to see how well this worked? And then we have to have that conversation of, we got to let radiation do its thing. We got to let things calm down, because the MRI is going to look very abnormal after the radiation. And so I think it's a good point to point out that things swell, all that inflammation goes in, and it takes a long time for something that's been radiated to kind of cool down and calm down when we look at it either with MRI or PET scan or those sorts of things. And in my experience, that can be up to a year before everything's kind of
Correct.
completely calmed down.
Right.
And that's a little bit variable, but certainly 1 week after radiation is not the time to get a new MRI.
And just because things didn't shrink and go away doesn't mean it's not dead. That's the other thing I point out, is that the cancer could be dead, and it could just be sitting there as dead tissue, or as scar tissue. And that's probably the most common scenario that we see with sarcomas, is that it's dead, but it's just sitting there, and that's perfectly fine. And sometimes we can tell that it's completely dead based on how it looks on the MRI. But if we can't, we just monitor and make sure it doesn't grow. If it doesn't grow, it's dead.
Yep. Cancer just wants to grow, 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 baby.
Yep.
Lisa, I could see you have questions in your eyes.
Oh, so many. But one question is just a general question. So I know when you first see your patients, you talk to them just about, of course, a lot of information, the radiation, what is it, just all the things that we've been talking about. But then when you see them for follow-ups, are you just looking for acute or side effects that happen right away from radiation? And then could you talk about a few of those? Because I know we talked about the scary things that can happen, like a secondary cancer, but what are the things that can happen when you're getting radiation, and what are you checking for when you see them in clinic?
So when they're getting radiation, you meet with me once a week to see what side effects are going on and to manage them as they come up. The side effects that you have in radiation depend on what part of the body that you're treating. But independent of body location, most people have a degree of fatigue. And it's to be expected, because your body is going through a tough treatment, and it fatigues your body's way of saying, hey, slow down and rest so I can heal and recover from this. That's what I tell my patients. If you feel fatigued, go ahead and rest. Now's not the time to start training for a marathon. Just take the time to relax, let your body heal. If we're treating in the head and neck area, you could have headaches sometimes. You could have nausea, vomiting. If you're treating more in the mouth, neck area, you could have mouth ulcers from the radiation, pain, and difficulty swallowing. If you're in the gut, you could have nausea, vomiting, but also diarrhea and urinary changes. And if you have a tumor that's very superficial near the skin, you're going to see a lot of skin redness and perhaps some blistering and peeling. But those are temporary and they go away. Our first follow-up after radiation ranges anywhere from about a month to 3 months, depending on how you tolerated the treatment and depending on the plan overall with like chemo and imaging and so forth. At that time, we're assessing, kind of making sure all the acute side effects went away. And then we enter surveillance mode. And surveillance mode depends on age of the patient and, again, what body location we're treating. If I'm in the brain area for a growing kid, I like to get at least annual eye exams, make sure their vision hasn't changed, hearing evaluations, make sure hearing hasn't changed, annual pituitary evaluation, perhaps catch an endocrine deficiency before it's a problem, and then also neurocognitive evaluation, see if there's any changes to how you're thinking and processing, especially if you're in school. We want to catch it before it becomes a problem.
Thanks. And you just mentioning hormones made me think about fertility. And because a lot of patients with Ewing sarcoma can have these big tumors in their hip. And we've talked about fertility preservation. And then from a radiation oncology standpoint, we know, the ways that we could try to help our patients, if they can do, if they can preserve their eggs or do sperm banking, but what can you all do to try to minimize the damage for radiation in that area?
Yep, exactly. So I definitely think about that, especially when I'm in the pelvis and I have a young woman of reproductive age. So things we can do, we can use protons to help minimize dose to the ovary as much as possible. Sometimes that may not be enough, and we work with our colleagues in gynecology to sometimes move the ovary away from the area that we're going to treat. And so it's called oh my gosh, you're going to have to cut this part out.
No, we did this already.
No, we
and
just
us, Abagupta, none of us could say it.
No.
Oophoreprexy.
Yeah, so it was the same.
Ovarian transposition is what I call it.
Yes,
Oh, that
because
makes me
no
happy.
physician can say it other than the one probably doing the procedure, and maybe that's
Or for
questionable too.
we've all messed it up.
So yes, you can move the ovary to, and so I would tell them where to move it to, and that would minimize the dose as much as possible. You can do the same thing actually with the testes to some degree too, but we can generally do a better job with pelvic sarcomas and tumors of limiting dose to the testes because they're an external organ away from our target usually.
Yeah,
Excellent.
thanks. That's very helpful.
Excellent. You're looking at me, Lisa. I can see you looking at me.
Oh, I just didn't know if you had another question or because I could keep on asking questions.
Yeah, keep asking.
Okay, so my next question was going to be still kind of in the clinic area, but more that I know when, and is this still true? So that with radiation, you usually try to keep patients' hemoglobin higher, so usually above 10. So a lot of times they'll have to get maybe an extra transfusion where if they weren't getting radiation, you don't want it as high. Does that still hold true? And why is it that you try to keep their red cells a little bit higher?
Yes. So that is an area of debate still to this day. There's certainly data, especially with cervical cancer, that keeping the hemoglobin up helps. The reason being is that you need oxygen to help the radiation be effective. And if you have low hemoglobin, you have basically lower theoretically ability to oxygenate the area that you want to treat. Not all cancers focus on that. So cervical cancer is one. And then generally with sarcomas, we think about that too. And for pediatric tumors. But I wouldn't say it's applicable to all cancer treatments within radiation.
Why is the oxygen important in radiation?
So the way radiation actually damages the DNA is that it creates oxidants. So there's two ways that it can damage the DNA. One is it can actually hit the DNA strand itself and cause damage directly. That actually makes up a minority of how DNA damage occurs. The majority of the way the DNA is damaged is that it actually hits water, so H2O, and oxidizes it. So you have an oxidized, basically oxygen molecule that can go, and then it kind of gets attracted to the DNA, and that creates DNA damage. So you're creating an oxidant that will cause DNA damage. So we've all probably heard of the terms antioxidants.
Ah, you knew where I was going.
Yes, antioxidants, where they're like, take antioxidants because it helps with repair DNA, it helps you be younger and so forth. So the antioxidants are basically eating up the oxidants. So, and I generally tell patients during radiation, we want oxidants, like don't go overboard with antioxidants. We want the oxidants to go in and do the DNA damage. And so I like to tell patients that if you are big on the supplementary medicine side of things, the complementary medicine side of things, that's great, but please talk to your radiation oncologist. It's not that we don't want you to take these agents. It's just that we want to make sure for the limited time period that you're getting radiation, it's as effective as possible. So we want to know about what supplements you're taking. We'll review them and sometimes tell you to stop it temporarily because we don't know how it interacts with the radiation.
Yeah, and they're going through this tough treatment, and a lot of times, the first time that we treat something is the best time that we have to treat it, and we want to make sure that even a theoretical risk to lower the efficacy of your radiation, we want to make sure that that doesn't happen. So, no hypervitamin C.
No. No.
I'll just throw it out there. I'll just put it out on the table. No hypervitamin C.
It's, and there's certainly a role for supplementary and complementary medicine.
Yeah.
It's just during radiation, it's a temporary break because I want to make sure your treatment that, you're changing your life to be here for is as effective as possible.
Yeah, absolutely. Absolutely.
Yeah. I think that's so important. And I'm glad you brought it up because for all aspects of medicine, I think when I was getting my MPH, that's something I got it when I was already a physician. So it was something I thought about a lot, about making patients comfortable to tell us these things and bring it up and ask them, because I think they're just scared because their family member told them if they didn't take this mushroom that their cancer wasn't going to get cured. So then they're scared to tell you because you might tell them no, but their grandma told them that was the only thing that was going to work. So, it is really important because it's not that we don't want you to take supplements or we don't have a lot of information. So we have to use the information we have and so we can optimize your treatment. Like you said, you're taking all this time, 20 days in a row to get the radiation. You want it to work the best that it can.
Right.
So if somebody has a cancer, a sarcoma, and you treat it with radiation and it comes back, so they have a relapse or a recurrence, and I, as an oncologist, say, hey, Dr. Ahmed, can you look at this and see if we can give more radiation? Is there a point where you have to say that particular area of the body, we can't give any more radiation? And if the answer is yes, why does that happen?
Yeah. I'm asked that often, especially the last week of treatment by patients because, they're finishing up and they're wondering what next steps are and possibilities and million thoughts in the head. As expected. I have done reirradiation, and I think with the facility we work at here, we see a lot of reirradiation cases. It depends on a number of factors. It depends on the technology that you have available. When you're reirradiating, you need to be especially mindful of the normal tissues, like if you're reirradiating near the spinal cord again. And so proton centers are probably more likely to see reirradiation cases because it's a more effective tool in that setting for protecting tissues. You have to think about how much time has passed since the prior radiation course. Tumors can heal and recover, and the way in layman's terms, the body can forget about certain doses of radiation, and you probably have more wiggle room. So the longer in between each treatment course, the more wiggle room I have to give treatment, basically. I also have discussions with my colleagues in a multidisciplinary setting. Is there something else we can try? Like, how effective is chemo going to be? Can you do surgery? And if answers are no, it's not going to be effective. We're only going to harm the patient. And if we don't treat the tumor somehow, that could also hurt the patient. Then you might say, well, the risks are higher with reirradiation. But if we don't do anything, the risks of tumor growth are also there. So you have conversations with patients about the potentially higher risk. And many of them in that setting, unfortunately, you're stuck between a rock and a hard place. And they understand the higher risks and want to proceed with it. Some don't. Right. And then finally, most importantly, I think is actually patient goals. And I kind of alluded to that with patients, is having that conversation with them. What risk are you willing to accept? Do you prioritize quality of life over treating your tumor, or you want everything done to treat your tumor despite the risks? So I let patients help me decide how aggressive to be in that situation.
One thing, this is like completely not going to flow in the podcast, Lisa, but it is what it is. I am who I am. One thing that my patients will often ask me, maybe not so much now that I'm here, but some of the acute or like the during radiation effects, a lot of what we struggle with or deal with is the skin toxicity, like the skin irritation, the redness, the sores, et cetera, et cetera. And they'll come to me and say, what should I put on this? And I always say, let's talk to our radiation oncologist, because you guys are the masters of the lotions and all of the things to protect the skin. And so I guess I kind of just wanted to reiterate that even though you as a radiation oncologist are doing this fancy planning with the computers and the synchrotrons and the accelerators, you're also an MD and you also take care of these acute side effects of your treatment. And so that's that multidisciplinary team. And so if there is a problem, you are able to address that problem better than I can. And so what are some of those, besides the skin that I just talked about, what do you think for sarcomas are the things that you treat the most in your clinic, that I keep punting to you?
I've never had issues with you punting stuff to me.
Oh, I've only been here a couple of weeks.
Yeah, so definitely with sarcoma skin, and it, like I said, depends more on the body area. Like if I'm treating something in the abdomen and I'm concerned about nausea because I know how much radiation dose is going to the gut, I will actually pre-medicate patients with anti-nausea medication because being nauseated, I feel like is one of the worst feelings in the world.
Yeah.
So I'd rather not have that. So I definitely prescribe anti-nausea medications. If that one pill before treatment isn't doing enough, we'll increase frequency, we can increase dose, we try different agents. If you're having diarrhea, urinary discomfort, we can prescribe medications for that too. I think the hardest treatment is head and neck treatment, especially with mouth sores and so forth, and pain while swallowing. And we have medications to help with that. And it's just tough. And so we'll also sometimes arrange for IV fluids if patients are dehydrated. And worst case scenario, if we can't get them to maintain their weight despite transitioning their diet to shakes, kind of more boost type things or protein shakes or whatnot, and not working with a dietitian, sometimes we do have to put a tube either through the nose or kind of into the stomach directly to help keep up the nutrition.
Yeah, I think that's a important point to bring up too, specific to sarcomas. I will often have the conversation with younger children, especially who have kind of face and head and neck rhabdomyosarcoma, to preemptively put the tube in so that it's there if we need it. If we don't need it, it's, we don't have to use it, but those are tough treatments up in that area for sure.
Mm-hmm.
And everybody, no matter the color of your skin or where you live, everybody wants to feed their child, and not being able to feed their child is very, very hard. So those things can help us through those times. So
Mm-hmm.
very good. I do appreciate all of the things that you prescribe for our patients to help them get through it.
Yeah, and then I was going to ask specifically about the lungs, because a lot of times we send you patients for radiation to the lungs, and if you see a lot of side effects, or not as often.
Yeah, and how do you do that? Because you can't stop breathing.
Right. So
And you're
when
moving.
I think of lung treatments, I think of kind of two situations. I have treated many kind of chest wall sarcomas where the lung is nearby, or I have also treated a couple of heart sarcomas where the lung is nearby. With that, we are looking at lung numbers and trying to keep it as low as possible. Usually you don't have breathing issues during radiation. The lung, though, can get inflamed and irritated from radiation, and sometimes patients will have shortness of breath with that, or cough and a low-grade fever, and that usually happens about 6 weeks to 6 months after radiation, and it's temporary and it goes away. So our fancy word for it is radiation pneumonitis. I'd say the vast majority of patients, if they have inflammation of the lungs, it just shows up on a CT scan and they don't have any symptoms. If you're having symptoms and it's limiting your ability to walk, to live life, then we would prescribe several weeks of a steroid, and that's usually enough to take care of it. So those are just for tumors that are around the lung. Ewing sarcoma patients, rhabdomyosarcoma patients, if you have disease in your lung mets, then we'll follow up after chemotherapy with whole lung radiation. That dose of radiation is actually quite low, and it's designed to just clean up microscopic disease. Patients do well with it during treatment. They don't have any issues or concerns, but that risk of radiation pneumonitis after we're done is still there.
And will they be able to scuba dive later on in life? Or is that always a no if you've gotten lung radiation?
I have never heard that before. Where did you hear that? Was it
I have. I don't remember if it's in the COG guidelines, but yeah.
that
Oh,
you
that's
can't
so good
scuba
to
dive?
know that it's false.
You can't
Yeah.
scuba dive? I wouldn't say
Because
it's
of
false.
like
Now
damage
someone's
to the
gonna go
lungs.
scuba. I don't limit my patients' ability to participate in aquatic activities after lung radiation.
Aquatic activities.
Good. I love it.
I've never
I
heard
love
that
it.
one, Lisa.
Oh man. Maybe we just asked in the
Well, like if
desert
you
where
have a
why are
bad
people
skin
scuba diving?
reaction, if you have a bad skin reaction during radiation, I don't want you going into the pool because of chlorine.
Right.
and,
Oh,
like,
yeah.
hot
No, it
tub,
was
you know,
more
things like
because of
that.
the changes in pressure when you're scuba diving. And then if you've had like damage to your lungs, from radiation, that it would cause some kind of side effect. But you would know if this I'm sure it
Right.
would be something
Right.
that they teach you in residency if it was something,
Or I
you know
just
what I
completely
mean?
missed that through all my training.
No, I don't think so.
I mean,
There's
we
no
monitor
scuba diving in Minnesota.
we monitor, lung function. Like we'll get lung pulmonary function tests.
Yeah.
We keep an eye on things. So
Good. No,
Yeah.
that's
Fascinating.
great.
This is awesome, Dr. Ahmed. This is really, really, really helpful. I think I've gotten better as the years have gone on with prepping my patients to go meet the radiation oncologist. But when I started as a younger oncologist, I felt like I wasn't adequately telling them what to expect when they were heading to the radiation oncologist. And so I think it's a scary time. Surgery is scary for our patients. Chemotherapy is scary. There's all these kind of benchmark points where there's a little bit of an unknown. And then once you get going, you kind of know what's happening. And I think this conversation will be helpful for people that are prepping to go meet their radiation oncologist, to talk to their oncologist about going to meet a radiation oncologist, and just understanding proton, photon, X-ray, synchrotron, like all of these things. There's a lot of information out there to sort through. So I think this has been so enlightening, super clear, super helpful. And I'm so glad that A, I work with you now, and B, that you came on our podcast to kind of break it down for our listeners. I think it was going to be a good episode.
Thank you for having me. Last thing I wanted to add, because people always ask this.
Yes.
So getting radiation itself is not painful. You don't feel anything. You're not going to be radioactive, so you don't need to keep your distance from anyone. And unfortunately, you won't have superpowers of any kind. So I wish that was the case,
Peter
but that's
Parker.
not the case.
Peter Parker.
Yep. Nope.
Yes.
Not going to happen.
And I did have one last question for you. I know everybody's got to get going. But, I have to say that everybody in oncology, all of our team members are always super caring. But I really do feel that about the radiation oncologists that I've worked with. You all are so brilliant, but also so caring. And I was just wondering what led you to radiation oncology, because the physics alone scared the crap out of me.
Yeah, I know.
That I could never do it. So, yeah, what led you to